I apologise in advance that the title of my talk is different from the one you have in your program, but I'm entitled to change those things around. It was some time ago that I agreed to Simon to do this talk. So just recognise my collaborators, David Gonzalez, who's actually a fellow within the CRE. He's also a gun research fellow, which is a bequest that we obtained many years ago and which we're very grateful for from a family in South Australia. Now, getting this right. So we've got a number of projects that we've been working on over the years, and these are 4 of them, and we also have one in the future about health-related quality of life. In actual fact, we will I'll be talking a lot about health-related quality of life in this presentation. So just going back, so very briefly, we received some money for an NHMRC study around cardiovascular disease, and we recruited 20 practices in South Australia, Queensland, and contacted all the people who had cardiovascular disease, asked them to complete some questionnaires about their current management and their current experience, including health literacy and quality of life and a variety of other questions. The South Australian Health Omnibus survey is an annual survey in South Australia to look at health in the South Australian population. It's quite a large survey, which is conducted by a group headed by Anne Taylor, and we put in some quality of life questionnaires for the 2015 survey, and I'm going to report on those. The North West Area Adelaide Health Cohort Group was set up by the University of Adelaide back in 2000, and it's following about 2,500 residents of a lower socioeconomic area in Adelaide, up near the Port Adelaide, and the northwest, and they've been looking at risk factors for cardiovascular disease, diabetes, and general health behaviours in this cohort over the past 16 years. And again, they've got quality of life data, which again, we're going to be looking at. The National Prescribing Service is a Commonwealth-funded body, which is about improving the use of medicines or quality use of medicines in general practice. And about 4 or 5 years ago, they were funded by the Commonwealth to collect morbidity data or general practice data from approximately, I think the figure is now 500 general practices around Australia, 3.5 million patients. It's a huge database and very useful for the purposes that we have in terms of monitoring what is happening in general practice, what the prevalence of various conditions are, at least according to GPs. I won't go into the data quality issues. Okay, so that's Dr. Tori Wade, who was our CRE fellow. She's a GP and had an interest in mental health. And Dr. David Gonzalez, who did his medical training in Ecuador, went to Brazil and ended up here with his wife and now soon to be 2 children. So that's great. You can see that, yes. So Tori had a big interest in telehealth. And so she did a review of the literature around telehealth, and we got it published. And the reason for doing that is because telehealth is actually a way of reducing cardiovascular disadvantage, because it's very useful in rural Australia to be able to use services that are usually only available in the city to be able to transfer some of those skills-based into remote Australia. What that review showed really was that telehealth is very useful, or has been shown to be very useful in all the studies that we looked at, for acute cardiac conditions, stroke, rehabilitations, and works well, but less so for chronic cardiovascular care. And although in some circumstances it has worked well. So that was some of the key points from that particular paper. She then did another study which was funded by the FRACGP, which was to look at a thing called eCare. And eCare is hang on, where are we? Of an online patient engagement and practice management system. So effectively what she set up was, on the internet, she set up a system whereby patients could go in and monitor their own care and actually sign up for various programs around, for instance, obesity management, general health care, preventive health care. But it also allowed the GPs to interact with that patient in a way that is not necessarily innovative in the world context, because this has been done overseas, health management organisations in America, but perhaps hasn't been exploited as much as it perhaps could be in Australia. And so what she was wanting to find out was whether this was going to be acceptable in the Australian context. And in both practices that were part of this study, one was in a low socioeconomic area in northern Adelaide, and another was in Port Augusta, which is a rural location. And what she found, we've got a paper under review at the moment, was that it was acceptable to both the patients and the practice staff. And she's also got some results around the patients' interactions with the various online modules and whether they were successful in helping to ameliorate risk factors for cardiovascular disease. Now if we just move on quickly to the NHMRC CVD secondary prevention project, which I mentioned earlier, that was published in PLOS in 2015. Effectively what we showed that inadequate health literacy contributes to poor physical quality of life, but does not affect the mental component. And that seems to be a bit of a theme across all of our quality of life research, is that when you have difficulties with quality of life, it tends to be on the physical rather than the mental component. And I hasten to add that we're actually controlling for a number of factors here. So we do actually control for reported mental health problems, being on medications for depression or anxiety. So we control for all of those things. So if you get those out of the mix, we're actually finding that mental health is not so affected by certain things compared to their physical component of quality of life. And I guess what you can see up here is that health literacy was defined as inadequate, marginal and adequate, and quality of life, the physical and mental components. And here it's statistically significant between the three groups, whereas not on the mental health. So what can we say about that? Increased health literacy may improve quality of life and reduce the impact of ischemic heart disease among patients with chronic cardiovascular disease. So it's an aspect of care that perhaps as GPs we haven't actually been engaging with, thinking that, well, if we improve the health literacy of our patients, that we actually get some sort of clinical benefit. I must admit as well that we currently do not measure quality of life routinely in general practice, but that's something that I want to change in the coming years, utilising the National Prescribing Service and other groups to try and incorporate it into the care plans that we use in general practice to monitor patients' health. And that's particularly relates to cardiovascular disease, but potentially can relate to any disease. And I think that quality of life is an outcome in itself. It's not just whether you've achieved your hemoglobin A1C level if you're diabetic. It's actually whether you've actually got good quality of life should be a measure that we as clinicians, not only as GPs but as practice nurses, everybody in primary care, should be trying to achieve. The Health Omnibus study, all of South Australia, we've got 1.75 million people, and the survey was undertaken in the spring of 2015. I think these results are based on about 2,500 participants in that, so it's across all ages, and we confined these particular results to those aged 30 and above, because cardiovascular disease is not necessarily relevant to the younger age groups. And so we measured all sorts of things. So we asked questions about quality of life, but also about their self-reported heart disease, gastrointestinal disease, mental health, and other people actually buying questions as well. And with a bit of negotiation, we actually utilised their questions, and they can utilise our quality of life questions. And it's led to very successful collaborations with several people that I would not have otherwise worked with. And I've learnt a lot about other areas. And that's led to a few publications here. So that's lower educational level and unemployment increased the impact of cardiometabolic conditions on the quality of life, results of a population study in South Australia. I'll define cardiometabolic conditions in just a second. So here we go. We've got physical component of quality of life, and then you can see the trend as you go from none, so these are generally healthy people in this survey, to those who've really have only got obesity, to those with a metabolic risk factor, and a metabolic risk factor was any of the following, including hypertension, diabetes or dyslipidemia, but without cardiovascular disease. So these are people probably being managed for that risk factor with some tablets or something like that. And then finally those with cardiovascular disease. So you can see that those with cardiovascular disease are doing the poorest in terms of physical quality of life. Interesting enough though, with mental health, it's pretty much across the line. Now, this is we're looking at educational level here, and we're looking at working status. And bear with me, you can see here that this is none of the cardiometabolic conditions. This is with the cardiometabolic risk factors, and this is with cardiovascular disease. So you can see in this, with the bachelor's and trade qualifications, probably no difference across the groups, but as you go into these groups who have got lower education, you've got significant differences between those who have none of those conditions to those who have all of these conditions, or one or other of these conditions. And the same over here with working status. And I think if I go like that, it just circle it. So low education level and unemployment increase the adverse effects of cardiometabolic conditions on physical health-related quality of life. Another paper which has just recently been accepted this month. I haven't got the proofs yet. This is an interesting way of presenting data, these Venn diagrams. But basically, I'll just quickly go through. I don't want to go over time. The prevalence of adequate lifestyle habits is no different between individuals at risk with or with heart disease than those who are healthy. And I think that's an important message to take away, is that hopefully you would imagine that having a cardiovascular condition would actually mean that you might be more engaged with prevention, to trying to adopt better lifestyles, but it's not happening. So that is a problem for us as clinicians, to try and get people to engage with that. And later on we'll talk a little bit more about how engaging in some of these preventive activities can actually lead to improvements in your health-related quality of life. So you can see in the middle there that 10%, the magic 10% here, have all of these: adequate physical exercise, reduced alcohol consumption, adequate fruit and veg, being a non-smoker. And 4% have none of those activities in this cohort. This one here, though, probably backs up what we know already about secondary prevention of heart disease in Australia. And really what we're showing here is that only 48% of people with cardiovascular disease are using an antithrombotic agent like aspirin, or an antihypertensive, and an anti-cholesterol agent here. Individually, they're not too bad at 70%, but when you combine them all together, only half of them are actually on all three, which in the main, most people should be on if they've had a cardiovascular issue. So again, this mirrors what we found in other studies from being reported in the MJ and others. Finally, if we're looking at lifestyle recommendations, this was associated with a better physical quality of life, as well as a higher mental health score among those with CVD and healthy individuals. So, is it the chicken or the egg? Are these people able to do this, and therefore they've got better quality of life, or is it because they've actually got good quality of life that they're able to actually achieve these things and get on with it? But I guess that has to be tested in some other way. And interesting, if you're on all of those preventive medications for cardiovascular disease, an aspirin, an antihypertensive, a statin, it doesn't necessarily affect your quality of life. Why should it? Why should taking 3 tablets a day really help you that much? But this is just showing that that's the case. Okay, prevention science. I'll have to point what this slide shows. This is association between, individual conditions and physical component of quality of life. What we did here is that we had a lot of information about comorbidities, and we hypothesised that if somebody has one comorbidity, that's different from having 2 or 3. And then if you add in risk factors as well, that's going to be another thing that can actually cause you to have reduced quality of life. And so we started to group them together, and we had the metabolic risk factors, cardiovascular disease, including AF and MI and heart failure, gastrointestinal problems, musculoskeletal. This was based on what was asked in the Health Omnibus survey. So we were able to, this is all self-reported, I may add. And this is the differences with the negative of this. So this is the reduction in physical quality of life compared to not being obese. So you can see here with heart failure that this group here actually has the poorest physical quality of life compared to people who don't have, compared to all these other conditions. I mean, you may look at Crohn's, but it's not statistically significant. So if we go through, you can see that they are the two groups, those with osteoarthritis and those with heart failure, who have the lowest physical quality of life compared to all the other conditions and like that. So if we go to that, and then we started clustering it, so none, 1 and 2 under metabolic, cardiovascular, people can have more than one cardiovascular disease. You can have more than one gastrointestinal disease. You can have more than one musculoskeletal condition. So you can see here that it does vary a little bit, but there is a trend. As you have more of them, as you might expect, your quality of life goes down. And then we started combining them into 1 group, 2 groups, and 3 groups of various conditions, and you can see that musculoskeletal seems to have an effect on, which you might expect, on the physical component of quality of life. So if you've got severe osteoarthritis and you're confined because of pain because of that, it adds to the reduction in quality of life that is already there for those other conditions. So for a clinician, I've got to try and fix something which is hard to fix, but I know if I can improve it, that I can improve their quality of life. And I go back to the idea that actually quality of life is what people really want, particularly as we get older. Okay, key points. And I'll let you read those. I don't need to read them out. I'll give you a minute. Have I got a minute? 1 minute. Some of this is self-evident, but as far as we know, nobody's really been publishing this in the past, and we think we've got a sort of a nice, unique set of data. Northwest Area Health Study, I went through that. We're at stage, beyond stage 3 now, and we're hoping to do some of these similar, looking at confirming what we found in the Health Omnibus survey with a cohort study, because this is not relying on self-report. We're actually relying on measurements and verified diagnoses. And they've been collecting SF36. We've been relying on SF12 for our quality of life. So it's more detailed. So we're going to be able to confirm our findings in a better cohort study. So, okay. And finally, the National Prescribing Service, just to show you that it's a fairly representative survey. Except in South Australia, we don't have enough practices. Oh, mea culpa. We should have good representation in South Australia. It's really quite costly recruiting practices for this, even though it doesn't cost the practice anything to contribute their data. There is a lot of reluctance to share GP data with third parties, and that's what we've got to try and overcome. But this is interesting here. This was put together the other day. I haven't had a really good chance to look through it, but it does give you an idea of the numbers of people that were actually potentially dealing with atrial fibrillation, 50,000, cardiovascular disease, 150,000, stroke, 40,000, so on and so forth. So we actually have a potential database that can provide lots of answers. We've just got to confirm the quality of that data. So I'll leave it there.